The next part of our series here in the 13 Keys to Becoming a Damon Master Finisher really has to do with treatment planning to the face. We've talked about vision and imagination, and really when we talk about the vision and imagination of our cases, it's not just about the smile, because many times we can have vision of what the smile will look like, but we also have to have vision and imagination and think about what the face will look like before we ever put a bracket on. So the next step into becoming a master finisher has to do with treatment planning to the face. Now, when we talk about treatment planning to the face, what we talk about is that the Damon system provides an avenue to save the face versus extracting for space. Now that might sound a little cliche, and we've heard this before, but it really is true. We want to do everything we can to enhance the face, protect the face, and do it if we can without having to pull teeth and have that negative impact later on. So protecting, enhancing, really it's the mid-face and the upper lip, and that is the key to creating beautiful faces, is enhancing that mid-face and the upper lip. I'll never forget back in Rochester, New York, when I was at Eastman Dental Center, and Dr. Subtownley was our program chair and director, and we would spend hours looking at the face. It was interesting because I felt like that I had a fantastic background on how we really look at faces, and we evaluate noses, lips, everything else. The thing that was interesting though is that we didn't take it to a different level where we not only evaluated the faces, but we evaluated for how to protect or enhance the face. What we did is we evaluated, and then we said, okay, well, it looks like the CEF has said that the teeth are out of position, or there's 6 millimeters of crowding, so now we're going to extract teeth. There's a difference here. And back in 2000, when I met Dwight Damon, he was very big on saying we're going to treatment plan to the face, and I thought, well, we've already done that in residency, but it didn't do any good because we were still extracting teeth and impacting the face for the negative. But Dwight explained how we can use the Damon system to get arch width and really increase arch length by doing that, and making it to where we don't have to extract teeth as much, and at the same time we're protecting and enhancing the mid-face. The face-driven treatment planning really means that I'm looking at the mid-face, including the upper lip, evaluating for optimal support as the patient ages. And if you're like me in my practice, we have patients that are coming in, and most of my adult patients are female, and what they're wanting very specifically when they come in is to enhance that mid-face. They want beautiful teeth, but they also want to see what they can do about getting optimal support, so as they age more gracefully. This is a young man that came into my practice, and if you look at his mid-face, he just seems to be a little bit of small lips, and the mid-face just seems to be a little bit flat. And Dylan, if you look at his profile, now that's a slight obtuse nasolabial angle, but his face just screams that he needs more support in the mid-face. Well, in a case like that, you look intraoral and you see that he has 3 blocked out cuspids, and this would be a very simple case where you would say, I'm just going to extract upper and lower bis and make this case very simple on myself. Well, that doesn't do any good for Dylan as he ages. And again, when I think of what I was taught from Dr. Damon back in early 2000, is that we want to anticipate what these patients will look like when they're 40 and 50 years old, and do treatment or treatment plan for optimal facial aging. So not extracting teeth for crowding, but trying to open up spaces and make it to where he has a great facial features. So non-extraction treatment planning to the face, we want to protect that mid-face and upper lip to support the face during the aging process. And again, I said this a second ago, but we're creating beautiful faces not for the 13-year-old or the 12-year-old, but for the 40-year-old or the 50-year-old. And that's how I approach looking at the face. Again, to me, the most important aspect to this is that upper lip. And the question we really should ask ourselves is, how can I enhance or protect that upper lip during treatment? And really, it's the midface, in my opinion, that the Damon system affects for good. And that's why when we see these beautiful Damon treated cases, we have full mid faces, beautiful upper lips. Now, that's not to neglect the chin, because that, in my opinion, is second to the upper lip, is the chin, because we really want to have a well-balanced face. And remember that we're treatment planning with the chin in mind as well. So this is an example of a patient that I treated, and you might have seen this case before, but let's look at this case in just a little bit different aspect. Pre-treatment, this is Ondalen. Pre-treatment, you can see that she doesn't have as much support in the mid-face. You can see that the vermilion display on the upper lip is just a little bit, it's not as full as I would like to see, but once we treated her, and you can see that her final picture here, look at the mid-face and how much support that she has here. And if you look right in this region right here, she has more mid-face support. And then the vermilion display, the wet dry border, this wet part of the upper lip, is we have more upper lip support, and that's beautiful. Look at the lower lip, it's more pouty. So increasing these beautiful faces. Here she is in the beginning, and you can see that Ondalen's facial features just says, I need more mid-face support. And when we're all finished, look how pretty that is. We have a nice roll to the upper lip, and you know, we create this full looking mid-face and beautiful lips. That really is the ideal that we're trying to accomplish in treatment. And of course, upon smiling, you can see that she has an absolutely stunning smile, and we paid attention to things like smile arc and inclinations of teeth. These all affect the face as well and help us to have beautiful faces in our outcomes. I want to show you this case. This is a fascinating case. This case was treated at the University of Pacific by Dr. Tom Pitts, myself, and another orthodontist named Golnaz. And when we treatment planned her case, if you look here at Kayla, you know, she has good full mid-face. She has good full lips. Of course, when she smiles, her upper lip thins out slightly. But the one part of the face here in this case that bothered us was the lower jaw and the chin, because we had a pretty good upper lip here. So I love what Tom Pitts was inspiring in the residents and in myself as we looked at this case, and he treatment planned this and we executed with his help, but we went outside the box in our thinking here and what we could do to help this young lady and have a better facial features, because it was all about the face. And I love that about Tom Pitts, is that everything he did was about the face. If you look here, you can see there's quite a bit of crowding. She's slight class 2 canine and class 1 molar, but she has quite a bit of crowding. And the vision was to not do any braces, to put a Herbst appliance on, to reposition the mandible, to get a better facial feature. And then once we've been about 12 to 14 months with the Herbst, and we've redirected the chin and balanced the face, and we put braces on and correct things from there. Look at, she has kind of a fullness of a Bimax, even though she's a slight class 2. And if you look at, she's still waiting on a few teeth anyway. So this is a Herbst first, and enhance that face. If you can see that the amount of overjet she has here. But we're really going to have vision, and I love what Tom Pitts was envisioning here, is to really enhance and change that lower chin position. So her problem list included that she has, as far as skeletal, a slight class 2 tendency. She had her soft tissue, she was a convex profile, protrusive lips, also incompetent lips with a little mental strain in her chin, and thin anterior attached gingiva in the lower. The dental problem list was a class 2 molar and canine, blocked out canines. We had about 6 millimeters of overjet and crowding. Procline incisors, and we had a few little tiny teeth out of position, lower crossbite, and we're waiting on some second primary molars to fall out. So with that moderate curve of SPIE and that facial features, we decided to try something different. So improved facial features was our treatment goals. Class 1 molar and canine, alleviate crowding, get an ideal alignment, and of course we want a beautiful smile and a beautiful face. The treatment plan was for that Herbst appliance. We've talked about that. Then we'll bond upper and lower, level and align, and coordinate everything. So here she is. This is Herbst placed with 2 millimeters of activation. And you can see that back then we were bonding crowns on the 6s and the 4s. Today it's a little different, but the idea is the same, and the same outcomes is what we're looking for. Herbst placed and 2 millimeters of activation. You can see at 6 weeks into treatment, we activated another 3 millimeters, advanced her forward. We're bringing her forward, and yes, we're going to bring her to a complete class 3 for chin projection. And then we're going to use light rubber bands to just slide her back with her dentition and have a beautiful chin projection. Again, we're just advancing slowly. This is not a full advance out into an underbite, but an incremental, about 3 millimeters a time. Here's a survey. 5 months into treatment, 7 millimeters of activation total at this time. Advanced Herbst millimeters, 2 millimeters at that 5th to edge bite, 6.5. Now we're at 8 millimeters total. We're doing a check. 9 months into treatment, advanced 2 more millimeters, and look at the potential of taking that off here pretty quick. Here's 10 months with overcorrection. You can see we've overcorrected that, and now we're going to start looking at putting braces on. 13 months into treatment, remove the Herbst, bond upper 6 to 6. Now, because we're in a residency program, you'll know that things don't always go the way we want. So we started with the upper 6 to 6, and the upper 2 to 2 is low torque on the centrals, and the laterals. And these are old torque values, so I really don't want you to pay attention to those, but more along the lines of just knowing what we're trying to accomplish, reducing the flare and on the upper and the lower. So here she is at 13 months. We bonded the upper arch. In the residencies, the attending physician or doctor will bond one side, the resident will bond the other, and then we're just going to work on sliding this jaw back with the teeth back, in other words. You can see this is a D2 bracket, and you'll see that things start to unravel here pretty quick. 18 months into treatment, we've put a 1425 on the upper and engaged the 7s. We've bonded the lower. So this is about 6 months into braces, and we've done some low torque. And you can see we've got a little mix here with the MX bracket on the lower and the D2 on the top. Full class 3, and then we're going to start using some rubber bands to tease that lower arch back into place. Notice good mechanics here. Upper arch looks beautiful. Here she is at 20 months into treatment time, and we have an 1825 copper knife tie in the top, 1425 copper knife tie in the lower, and we've just been doing some quail class 3s and a short version here to help us to get that lower teeth to come back. You can see we're maintaining control. Here's our elastics, 24 months into treatment time. Very, very light rubber bands. Today I would probably do this differently on an 1825 and a 1425. I probably would just take from the cuspid all the way back in a short, a full length parrot from the molar to the cuspid, but you learn as you go here. Again, we're using a little trapezoid or a rainbow in the front with a light rubber band to help keep the vertical under control. So that's 26 months into treatment. You can see we've used some, with the D2 bracket, we've used some other types of, we didn't have drop-in hooks back then, so you can see these Kobayashi ties for our anterior elastics. Good control. We're at 32 months of treatment time. Look at the occlusion. Now this is treated in the residency. Remember that. 34 months, we've cut the wire distal to the 3s. I don't routinely cut the wire, but we've done this in the past. Use some ostrich up and downs in some triangles to really get things to settle into place. 35 months into treatment with debond. Now I want you to pay attention really closely here, because this smile in case looks beautiful. I want you to skip the rest, skip the smile, but look at her profile. She actually has a chin projection. We've completely changed her facial features, and changed everything for her with her face just by having some vision. Now look how beautiful this is. You can tell this is Day of Debond, obviously. And this case only gets sweeter in time as we've been off. But look at the class 1. Beautiful treatment. Maintain the incisal inclinations and the torques. Just a absolutely beautiful case. You can see here now, this is her before and after. Look, no chin. Repositioned that lower jaw, brought it forward, balanced out her face. She has a beautiful face. Look at the vermilion. The mid-face still looks beautiful. We don't have that mentalis strain anymore. Her profile, just absolutely gorgeous. And so by having vision on the facial features as well, we can design our mechanics to enhance the face at the end of treatment. Sometimes this is an unconventional approach, but whatever it takes to balance out the face. And I really don't think that we as clinicians have really explored all of the options and pushed the envelope for doing these treatments that are unconventional, but getting that beautiful facial outcome without doing surgery or other invasive procedures. Here's retention 1 year later. I want you to see, look how pretty her facial profile still is. Her smile is gorgeous. The teeth have maintained. We've used a Damon splint to maintain that jaw in a forward position. She just looks gorgeous. The tissues are great. I suspect this is one of those cases where 10 years down the road, we're still going to be looking at this beautiful class 1, beautiful face. Good retention. These are our same retention protocols. We'll talk more about that in future casts here in study clubs. So if we go back for a second here, when we treatment plan for maximum smile aesthetics, we're going to have that beautiful face. But to accomplish that, let's break this down just a little bit more when we're treatment planning to the face. By treatment planning to the upper incisors, then that helps us to accomplish the most beautiful lip roll and lip drape by putting the incisors in the right position. So going in hand with facial treatment planning becomes where we break this down and go into the mouth. Now we're treatment planning the upper incisors to the right position. Now that position is in the sagittal for enhanced soft tissue aesthetics, vertical for the smile and for rest position, and then we obviously for our inclination for proper torquing. So the upper incisor is most important in this facial treatment planning. Now these are examples of movie stars with incisors that are off-center, flared, or misaligned. But yet, isn't it interesting that the public still thinks of these people as beautiful smiles? And I think it's our job to really educate and help people understand how important the upper incisor is when we finish our treatment. Look at these. These are other stars that just have incisors that are just not in the optimal or ideal. This is a case that I treated. Now, patients are constantly looking at their front teeth and they're wanting to change that position. But when we treatment plan in a beautiful way, we get enhanced facial features and a beautiful smile. This is a patient of mine that I finished, and I had done a clinical trial braces on her, the Clear, Damon Clear, probably 8-9 years ago. And unfortunately, we didn't have a low torque clear bracket, so I fought the little bit of flaring. Even the slight procline incisors really do detract from a beautiful smile. And you can see now this is a beautiful smile, but she's slightly flared in the anterior. So we want to pay attention to where those incisors are. All patients want to maximize aesthetics. And how do they do that? How do we do that? Well, we treatment plan those upper incisors to be in the right position in all four planes of space. We've talked a little bit about that, but we don't want to forget all four planes. And that last one, I think, being most important is axial inclination. Paying attention to the upper incisor position is critical for maximum lip drape, lip support and lip drape. It's the upper lip that is the most important part of the face, and we've talked about that. So what we want to do is pay attention to get the incisor exactly where we want to be. Now I show this picture of Richard Eastham because Dick was awesome clinician, and obviously he was one of the. It's funny. Dwight talks about how Dick Eastham was one of his instructors at Washington. But Dick became a great orthodontist and mentor of all of ours, and he paid attention to where that upper incisor should be in treatment. And I love this study. I've referred to it many times, but it's the Eastham study of evaluating the labial inclination or angulation of the upper central incisors at the end of treatment. So what he did was Dick took a sample of his own cases, finished cases, 35 of them, that he felt like that were some of the best finishes and incisor position at the end of treatment. Then he had other orthodontists send him 25 cases of their own that they felt had the best incisor position. And then he got some other cases from other people, some ABO board cases. He took 64 of those. He took 41 angle cases, and then Dr. Wolford, the surgeon in Texas, he took 50 of their treated cases where they actually had surgery and finished up with the incisors in the position, so in the right position. So the sample was 250 treated finished cases that orthodontists around the nation thought that the incisors looked the most beautiful. And then he went and evaluated the position on a Ceph to see what that position was. So here is his sample of 250. He has the upper incisor, and he wanted to find out what was the most aesthetic torque position. And what he decided is this part of the facial surface of the tooth was that there was a line that would bisect this from the excuse me there, a little loss in my train of thought, but Frankfurt horizontal, that natural head position, and a plumb line, a 90-degree line here dropped down, and where it bisects that upper incisor and tangent to that upper incisor, that would be 90 degrees was the optimal position for that upper incisor. So most aesthetic position with a tangent 90 to the surface of the upper incisor, and that would be the position of the most aesthetic position of the incisor. Now, what he also said was that when the incisors are in the right position, they reflect the light to the outside world and really bounce the most beautiful aesthetic and enamel for the smile. So this really affects the lip, but it also affects the smile. So that is treatment planning to the face.